Okay, so today I want to talk a little bit about left bundle branch block, so an activation abnormality and what the consequences are for cardiac mechanics and what we can expect and how we can evaluate it also. This actually fits in partly in the discussion is like, how do we, for example, approach something like heart failure? Right? Because heart failure is a syndrome. It's not like a certain etiology. It's not one disease, let's say it that way. It's something that the patient experiences and that you can see in different ways. And the thing is that there might be quite a lot of different etiologies that would lead to heart failure. So I think it's really important that if you would assess heart failure patients, then you need to try to identify these etiologies. And obviously, in order to identify them, you need to know them. So you need to find specific parameters that can tell you or that can discriminate different etiologies. And so that's why I want to discuss today one of these etiologies that can lead to heart failure, which is related to an abnormal activation system or an abnormal conduction system. And then later on, we can see that based on this, you can actually determine the impact of a certain therapy. In this case, when it's some conduction abnormalities that lead to heart failure, we have a pacing therapy, which is called cardiac resynchronization therapy, but that will be then the topic of one of the next sessions. So now I want to concentrate on what would be the consequences of abnormal activation. So when we look at the conduction system, we look at the different problems that could be there, then actually problems can occur in all the different components of the conduction system. So we know when we look at the conduction system, so we have the sinus node, which is located in the roof of the right atrium. Then we have the atrial activation. So that also has to come, like you have to have the activation of the right atrium, but at the same time, you want to have as quickly as possible the activation of the left atrium. So we will see that interatrial delay, that might be an abnormality. Then what needs to happen is that, so as I mentioned before, the valve plane actually separating the atria from the ventricles, this is actually an insulating layer. So this is a fibrous layer where in principle there's no conduction of any electricity there. And the only connection between the atria and the ventricles is through what we call the AV node, so the atrioventricular node, which acts as a delay line. And then after a certain delay, so that means actually when the atria are activated and have contracted fully, what then happens is the electricity goes further. We come first into a common His bundle, as we say, and then we have a split off towards the left and the right ventricle, which is then the left bundle branch and the right bundle branch. And from there, if we enter in one of these bundle branches, we go into the Purkinje system, which is, as I said before, is at the surface, at the endocardial surface in human hearts. So all of this is in order to do very fast activation of one ventricle. So the problem is, of course, if you would have a disruption somehow of this Purkinje system or of the left bundle branch block even, of the left bundle, sorry, which is then called the left bundle branch block. What happens now is that the activation of the ventricle might be not fast enough. And so that means that we would have an intraventricular delay. And as we can see, there are actually different etiologies that can lead to this. First is really a true left bundle branch block, so where there's a problem with the conduction of the whole ventricle. Then we can see that actually this type of abnormal activation can also be induced. So for example, by pacing, or similarly like pacing gives you actually a abnormal early activation, which is not from the AV node and going through the normal system. So it would be, for example, a right ventricular pacemaker lead. Similarly, if we would have some kind of early activated segments, for example, if there would be a connection between the atria and the ventricles besides the AV node, as for example in Wolff-Parkinson-White syndrome, you can see also that you will have these early activated segments, which then lead to an abnormal activation of the whole ventricle. There might be some diffuse abnormalities of your conduction system, or another etiology which you wouldn't expect immediately to lead to abnormal activation, but we show later on how this can be, is when there's non-compaction cardiomyopathy. Now, as I said before, the other problems can arise either interatrially, but of course also atrioventricularly. Yeah? So if the speed of this delay is actually not sufficient, it's either too fast or it's too slow, you might have some problems. And then last, you can also have a difference or differential activation of the left and the right ventricle, which in some instances can also lead to any abnormality. So it really is important to try to understand these different underlying conditions and what the consequences are. And then, of course, if we understand this from the mechanical pathophysiological point of view, then we can also find, of course, parameters, imaging parameters, ECG parameters that are related to this and that can help in detecting these separately. As you can already imagine, and that comes back also when we're going to talk a little bit more about selecting candidates for cardiac resynchronization therapy, the fact that you have all these different etiologies will likely mean that there's not one parameter that you could measure from a single imaging modality, which would, for example, give you the answer, which would say like, okay, this patient is in heart failure because of a conduction abnormality and would respond to a certain therapy, yes or no. What you really need to know is you have to understand these different etiologies, and based on this, try to go through them and try to understand. So as I said before, in order to understand abnormalities, you need to understand normality. And so let's look at the normal activation. So as I said before, normal activation of the ventricle is through the Purkinje system. Purkinje fibers are actually kind of collagen fibers. So it's a collagen sheet where you have internally what we call Purkinje cells. And Purkinje cells is actually the fetal phenotype of myocardial cells. So these are myocardial cells that have not transferred to the adult phenotype, let's say it that way. And that means that they actually still very fastly conduct. So they contract very much less than the kind of full cardiomyocytes, but they have the ability to faster conduct. Because as I said before, in the early fetal stage, when we do not have a coronary circulation, what needs to happen is that the perfusion has to come through diffusion, which means that you have like a very spongy myocardium. And there you also don't have a Purkinje system, so you need to have fast activation of the whole ventricle. That means that all the cells need to be fast conducting in order to do that. So these Purkinje cells make the conduction speed is about roughly 5 times that of normal myocardial cells. And so that means that they very fastly activate the endocardium. And when we look at the contraction of the myocardium and say that we would have the ventricle, for example, like this, and say that we, for example, start from the septum, because the left bundle is at the septal part, so at the basal septum. And then the Purkinje system is starting. So the first activation would be roughly kind of mid-apical septum, where you have the first activation. So when that segment is activated, obviously it starts to develop force. So it starts to contract in some ways. But as we said before, the first part is force development in order to generate pressure. That then can open the aortic valve, and then you start to get deformation and shortening. But so what happens is this segment is starting to contract. So all the myocytes they are activating, they're starting to contract. But as I mentioned before, what you have to keep in mind is that this segment is obviously connected to the other segments. So what happens is this segment is starting to contract and it starts to develop force on the neighboring segments, besides, of course, generating pressure, which is perpendicular to the endocardium. Now, what happens if we have a very fast conduction system is that obviously this neighboring segment is virtually activated at the same time. So that means that when this segment is starting to develop force and starting to interact with that segment, then this segment is actually doing the same. And as we said before, myocardial segments are very, very homogeneous in normal cases. So that means that this interaction force is actually totally canceling out. And what happens is that all the segments are now kind of working jointly. And what happens is that because all of them contract in the same way and they only kind of develop the pressure and do the deformation, what happens is that they would drag the valve plane towards the apex. And as you can see from this echocardiography, you see that everything actually is happening at the same time. Right? So there's no difference in when the segments go upwards for longitudinal function or when they go inwards for circumferential and radial function. So this is the normal activation, which what we would call is synchronous activation. And because of this, the isovolumic contraction period, so the period in which the force development is happening and then the pressure will rise, is relatively short, right? Because everything immediately that it's activated, all the force is being used in order to generate pressure. All the segments are working together, and that means that things are relatively fast. Now, what happens is if we have some of these abnormalities, so say that we have this intraventricular abnormalities where something is wrong with this, and let's start with the typical left bundle branch block. But before going into what it means, let's also look a little bit at some of the dynamics that we can really see and what we can measure, and that already point us in some ways to some of the things that we might expect. So what you see is, and this is why even although many people would consider it as old technology, M-mode is still very, very interesting, and especially in order to look at the dynamics of the septum. And then you see that all these different patterns. So this is really some old M-modes, but you see exactly the same still now. And as we said before, when you look here at the septum, a normal septum would have the systolic inward motion of both the septum and the lateral wall. And what you very often see, as we said before, is there's a little bit of post-systolic in the basal septum with regard to the opening of the mitral valve here, for example. So this is a normal, probably a little bit elderly person, but with a normal conduction system. Now, then we can start to see that there are some abnormalities. So here is, for example, right ventricular volume overload, and we'll come back to that later. What you see now is that instead of this post-systolic kind of thickening, where you really see that the post-systolic thickening, what you see here is that you have these early diastolic kind of interaction and inward motion. So there's something which is, it's not completely the same as post-systolic. So you see it's also different in duration, but you see that there's different dynamics, predominantly in the early relaxation. And we'll come back to that when we talk about pulmonary hypertension, for example. Now, if you have left bundle branch block, what you now see is that you also have this abnormal septal motion. But when you look at the ECG, this is actually at or around the activation phase. So although you every time see this kind of short-lived events, you see that there are different time points. And if you would have coronary artery disease, obviously nothing is happening. I mean, if you have, as we said before, if you have an infarct, nothing will be happening there. And even when you look at some of the other ones, so here is actually something similar. So here is actually a paper that is looking at different activation abnormalities. And you see actually that you might have different patterns which are occurring. And we'll come back to that later on. But you see always that there's something happening around the early activation phase. And then what happens then later on in systole might be very, very different. We can also look at that, of course, based on deformation, and I'll come back to that later on. And so you see that when looking at especially the basal septum, because that, as we said before, that's exactly where the activation is taking place, but that's also where there's a lot of interaction because of the local shape change, and where also you have the interaction with the left and the right ventricle. So that's actually quite interesting. And over the course of all the different talks, we will come back to all of these different patterns, but what we will focus on today is what you see in this left bundle branch block. And out of curiosity, and this is also one of the reasons why I would like to give this lecture today, is that actually what you see is that in some conditions, some maybe unexpected conditions, you can also see this type of abnormal motion patterns. And so here is actually a fetus with an aortic stenosis, where you see, so in this case, of course, the fetus, you don't know from which direction you're scanning. So this here, the septum is below. And you see again, this very early inward outward motion, which is different in timing, obviously, than this, what looks like a normal contraction of the free wall. So what is happening there? Why do we see these patterns? And why does this have a consequence potentially on the whole of the ventricular function, and then actually can lead to overt heart failure that then potentially can be modulated with, for example, pacing? So let's now come back to what is happening when we would have a left bundle branch block. So that means that we do not have fast activation through the Purkinje system, but we would have activation which actually would take place through the myocardium, so which is much, much slower. And so in order to understand what happens, we should go through the whole cardiac cycle. So let's start at the onset of the ventricular contraction, or ventricular activation. So at the moment that we start to have some ventricular activation, so the onset of the QRS complex, what happened, as I said before, is like if we don't have a left bundle in order to do the activation and then activate around what I said before, earliest mid towards apical septum, what we now have is, if the left bundle is blocked, very often we still have a right bundle which is abnormal. So that means that there was fast activation of the right side, and what we see is that from the right side now the electricity would travel through the septum, so transmurally to the septum, and we start to see that the first electricity, in case that we don't have a left bundle, is arriving probably again about the mid, maybe a little bit more basal in the septum than in normal cases. So the electricity is arriving there. What now happens is the same as I said before. The segment that is activated, the myocytes are starting to develop force, are starting to contract, and they interact with their neighbors. Now, of course, if this segment is activated and starts to develop force, but the neighboring segment is not yet activated, what now happens is that, of course, there's a one-sided force. So that means that this segment is starting to develop a force on that segment, at the same time trying to build up pressure perpendicular to the endocardium. But if this one is not activated yet, what happens, and that seems to be the case, is that when the tissue is still very elastic, so normal tissue, what happens now is, instead of building up pressure, what happens is that this segment is starting to stretch the neighboring segment. So that means that this segment can contract, shorten, and at the same time would lengthen the neighboring segment. Of course, as we said before, the electricity now is not going through the Purkinje system, but is going through the tissue. That means that obviously at some point it will arrive at this neighboring segment. Now this neighboring segment, which was stretched before, is being electrically activated, of course, starts to develop force, starts to shorten. And what we see is that now, by the shortening of this segment, it can actually do an interaction with the first activated segment. And what we see is that this actually can stretch the segment in return. So what do we see at the level of the ventricle then? So we can go first through this cartoon. So we see onset of the QRS. That means that the septum is being activated, starts to contract, starts to move inwards, and at the same time stretches the rest of the myocardium. A bit later on, the electricity comes to the rest of the myocardium. So in this case, the lateral wall. What now happens is that this wall starts to develop force, starts to contract. And what it actually does is it stretches again the septum and actually pushes out the septum because it's developing the pressure inside. Now, of course, that means that if this one is being pushed out, so the septum is being pushed out, that means that the only part which is still contracting during the ejection phase is actually the lateral wall. Keep in mind that this inward motion and the outward motion due to the stretching and activation of this all happens within the QRS complex. And also in left bundle branch block, the QRS complex, because the conduction velocity is much lower, will be much longer. So what we say is we have a wide QRS complex because of the fact that we have tissue activation rather than Purkinje activation. Now, as I said, then this lateral wall is now doing all the ejection. And what now happens is when we are at the relaxation phase, so what you have is that the lateral wall will have contracted fully and has pushed out the septum. Of course, now at the early relaxation, what happens is that the lateral wall relaxes and actually kind of makes the septum shorten again. And only when the septum is then back in its normal position, what you then have, you start to have the normal filling. So the interaction that you have in the isolumic contraction period, you also have in the isolumic relaxation period, making that both will be lengthened significantly. And I'll show you later what the consequences are of this. So that means that we have here early contraction of the septum, stretching lateral wall, then later contraction of the lateral wall, pushing out the septum. the lateral wall only doing the contraction, and then both the isolumic contraction period, the buildup of the pressure, because it's being done very late, because the septum now is not contributing to pressure buildup because it's just moving inwards and it's stretching the other wall. It's not building the pressure. It's later on when the lateral wall contracts that the pressure is really being built up. So that you have, and then as I said before, you have a very long isolumic relaxation time because of the fact that you have this interaction between the two, which means also that the negative dPdt, so the relaxation, and we come back to that when we talk about diastolic function. So the time constant at which the pressure will drop is also much, much slower. Here you see a very typical example. So you see either at normal speed or here it's slowed down. You can nicely see it here. So what you see here is when we look at it, so you see here the early inward, you see here inward outward motion of the septum. And then later on, when the lateral wall here is contracting, so you see that the septum is being pushed out and is actually being stretched. And then also in the early relaxation, when you see that the mitral valve is opening, what you see is that it's actually the septum is going back. So you see this very abnormal inward outward motion of the septum. At the same time, what you also see is that the apex is what we call like rocking. So you see this apex is moving. Well, we said before that the normal apex, because of the fact that all the forces balance around the apex, is kind of stationary within the thorax, although it's of course not connected to anything in reality. So we see here that everything changes in this way. How can we look at this? So one of the things is if we do an M mode, as I also showed before, now you can start to understand what's happening. So when we look at the M mode, you see the onset of the QRS complex. What you see is there, you start to have the inward motion of the septum pushing out the lateral wall. A bit later on, still within the QRS complex, you start to see that the lateral wall is starting to move inwards when the activation is taking place there, and is actually pushing out the septum. And during the whole of the ejection phase, the septum is actually being pushed out, and you see that it's only the lateral wall that is doing the inward motion. You see immediately also already that this is a very, very large ventricle because of the fact, of course, that this is very inefficient. So your whole septum, although it is normal tissue, what you see is that it actually does not contribute to the ejection. So you can look at it in different ways. So with the traditional M mode or peristernal view, you can use an anatomic M mode from a 4-chamber view, or you can actually also measure strains in whatever different way, where you also see what has been also called this pre-ejection shortening, and some people call it then rebound stretch. We have called the whole phenomena here at some point a septal flash, and that's very typical for what happens here. The reason also why we call it a flash is because if you would use the color M mode, kind of with the velocity of the tissue being colored in the different colors, you see that this is really like a color flash kind of coming there. And so that's why we called it. But you see already visually, if you look at this, you nicely see this inward outward motion in a 4-chamber view. You also see it in a short axis view. So there's a lot of different ways in order to look at it. Now, what is of course also important is, as I said before, if you have this, it has consequences for the whole kind of mechanics and working and efficiency of the ventricle. So when we look at the deformation, so the deformation of all the segments would start at the onset of the activation, and then you would have deformation throughout the whole of the ejection phase, and then you would have again the shortening or the lengthening in the longitudinal direction when we are in the relaxation phase. What now happens is that part of the tissue will first fastly contract, stretching the other, and then the other one is contracting while again it's stretching this. And when we now look at the work that has been effectively contributed to the ejection, what we see is that obviously while in normal hearts all the segments contribute, what we see in left bundle branch block, that the septum is totally not contributing to the ejection, and the lateral wall has to do everything. Now, different ways to look at it again is, for example, if we measure cardiac velocities, so myocardial velocities, you see here also, so normal versus the left bundle branch block. What you see is in normal velocities, what you see is in a normal heart, the fastest events are always the early filling. And so you see we have normally activation, so isovolumic contraction, which is not a lot of motion taking place, it's a little bit of motion. Then we have a continuous contraction, which is relatively slow, but then we have a fast early relaxation. That's what you see. So normal velocities are the highest in the early diastole. But if we have this left bundle branch block, what you see now is that you have really exaggerated velocities, which are now happening within the QRS complex, within the isovolumic contraction phase, instead of within the isovolumic relaxation phase. So you see that the dynamics totally change. What you also see is that when you normally look at displacement, or you would normally look at deformation, for example, where normally deformation is very synchronous and is happening the same everywhere, what you see is that it becomes very dysynchronous, and that's why they call it also kind of ventricular dysynchrony, where different segments are having mechanical events or contractions and relaxations at different time points. Now, it's easy to understand that we have fast inward motion, because that means you have activation, you have force development, and since there's no loading, in the sense that the neighboring segments are not contracting, the neighboring segments also haven't increased the pressure yet. So that means that you have a very low load in contraction. So that means that this segment can contract very fast. So this fast inward motion is normal, because you have force development without a counter force. So that means that it happens faster. Now, it's a little bit more difficult to understand why you would have this fast outward motion when the other wall is contracting, because what you would expect is, of course, that this segment is starting to contract and that you actually have cross-bridge formations, which means that it is developing force at the moment that the other segments are contracting. So that means that it does represent a load as compared to the other ones, which are not contracting yet. Now, what seems to be the case, and this is actually also quite relevant, I think, is that when you look at the physiology of actin-myosin, what you see is that it seems like we have different types of myosin also. And that means that if contraction is taking place at a low load, what we see is we have much less cross bridges and different types of cross bridges being used and being bound compared to when we have loaded contraction. So what happens now is if this one was contracted at a load and then we have counter contraction later on from other segments, what seems to be happening is that you really get a mechanical breakdown of these cross bridges, which were actually very loosely bound. So this outward motion, again, is probably not related to the fact that there has already been this kind of active relaxation at that moment, but it's really mechanically breaking down these cross bridges, and thus might also have some other influences. Now, if this is the case, that you work with the balance of the load versus the contractile force, and then the balance of the early contractions versus when and how much delayed contraction is taking place, then you can understand that there's different patterns depending on when this is happening and how much this is happening in patients. And this is actually what you see here is like, if you would look at normal contraction of the septum, as we said before, that starts and is then taking place during the ejection phase, then you have the relaxation. If you have like a little bit of tissue which is activated earlier, what happens is then you have this septal flash-like pattern. But if the contraction is happening against some load and we have a decent amount of cross bridges being bound, then when the lateral wall starts to contract, we might have a little bit of rebound, but still later on the septum can continue to contract. However, if we really have a full contraction against the low load, and then using, as we said before, this very loosely bound cross bridges, then we have what we can say like a full septal flash. Like what happens is you have inward outward motion, and then you have outward motion during the whole of the ejection phase. And when you look at patients with left bundle branch block, you really see the whole spectrum of this, going from totally normal contraction to a tiny flash to like really an overt flash followed by this outward motion. And I think that's important also to understand, so that there's not just one pattern, but there's really different types of patterns, depending, of course, on the whole mechanics of the ventricle that is taking place. Just to show you this as an example, we will come back to that later on when we talk about congenital heart disease or about right ventricles. So here is a child with a hypoplastic left heart, so a single ventricle, which is mostly of right ventricular kind of morphology. And you see there also, if you look at this, you can really start to recognize these abnormal patterns where you see that you have early contraction, which then less contributes to the ejection, while the late contracting segments are first being stretched and then continue to contract much more and much longer. So these are the typical patterns that we have to try to recognize. Now, what is also important is that when we look, for example, at metabolism, and we use, for example, nuclear medicine in order to measure metabolism and perfusion, for example, what you see now is that if we have a patient with a left bundle branch block, what we now see is that we see that the septum actually has a very, very low metabolism. So the use of glucose, which is measured by FDG in PET, what we see there is that the whole of the septum actually seems to have reduced metabolism. Now, of course, in case of an infarct, you would also get that. But what you see is when you start to look at for example, perfusion, you see, okay, perfusion might be down somewhat, but it's clearly much less down than the metabolism. So you're here in a situation that you see this heart and say, like, look, this looks a little bit like ischemia, for example, because with ischemia, what you have is you would have less perfusion and obviously less metabolism there if the myocardium is either being damaged or what we call being kind of hibernating or something like that. But what in reality happens is if we take the same patient and we do then resynchronization therapy, what you see is that actually everything totally normalizes. And when we think about the etiology, so where I told you before, it's like the septum is contracting very rapidly against the low load. That means that obviously it has to develop little force and has to do little work, which means obviously that the metabolism needed for this is much lower. So you get a downregulation of the local metabolism, not because of the fact that there's a problem with the tissue, but because of the fact that just the tissue doesn't have to work so much because it's contracting against the low load. And similarly, and this is now a pacing model, but similarly what you see is that the early region, so the septum in this case, would actually become thinner, while the lateral wall, which has to do all the work, as I showed before, what you see is that you get some hypertrophy there. So you start to get a differential thickness also as a result of this, if it is long-standing. Now, another thing which is also interesting is to see how this expresses itself and what happens if we would increase contractility there. What you normally have, as we said before, when you give dobutamine to myocardium, what happens is that the force development increases and your rate of deformation will increase. And what normally also happens is that the stroke volume will increase or at least stays the same. It's only at much higher heart rates, when we don't have time enough for filling, that stroke volume will go down. But definitely in the beginning, with low dose of dobutamine, stroke volume should increase and whole contractility would increase. But when you think about this situation where you have the left bundle branch block, and so you have this early activation of the septum, what now happens if you increase the contractility of the septum, what will happen is that, of course, you're going to exaggerate this early contraction even, because you give the same load, because the rest is not contracting yet, but the septum has higher contractility. That means that you actually get a even more pronounced septal flash, as you see here. And very interestingly, what you see now is that actually because of this increase in the exaggeration of the difference between the septum and the lateral wall, what you see is that immediately the stroke volume will decrease. And you see that here, when you look at your aortic outflow, you see that with dobutamine, you have a decrease of aortic velocities and a decrease of the amount of volume that goes out with every heartbeat. So you see something which is totally counterintuitive. And for example, also you can use this if you say, if you're not sure whether there's a septal flash with any important consequences for overall ventricular function, what you could do is give, for example, dobutamine, and then you will see whether this is happening, yes or no. And this can be, for example, if you have high end diastolic pressures. So if you have a patient that has high atrial pressures, high end diastolic pressures, it might be that this early septal flash is not so kind of obvious or prominent because of the relatively high pressures, then again, giving, for example, dobutamine, you can show this and you can exaggerate. So here you see how you have this interaction with the cardiac dynamics, the force development, the interaction with the different segments, and then the consequence on the global function, of course. Now, just to show you that this really is because of the mechanics of the activation, this is what is happening when you would use pacing in order to correct this. We'll come back to that in one of the next sessions in much more detail. But here you see a patient that clearly has within the QRS complex, as we said before, this very early inward-outward motion. So typically then the outward motion during the ejection phase. Sometimes you even still see, like here, you see a nice post-systolic. So you see this happens within the QRS complex. So this is septal flash. This happens in the early relaxation. So this is post-systolic. And of course, you get post-systolic here because there's a very differential difference in the contraction of, in this case, the neighboring segments around the apex. So that, as we said before, causes the post-systolic thickening. And if we do resynchronization therapy, so we pace, and by pacing, what you do is you pace the lateral wall so that at the moment that the septum is activated, actually that wall is also start to activate. So you more or less normalize the time of the force development. What you see now is that immediately when you start pacing, you see that the septum, again, compared also to the lateral wall, is starting to show a much more normalized contraction pattern, where the septum is starting to contribute. Now, the fact that we have this very slow contraction in the isolumic contraction period and the very kind of interaction of the segment in the isolumic relaxation period actually means also that the dynamics of the pressure is different, and that actually has consequences on when and how, for example, the mitral valve is opening and closing. Now, what you see is, we might come back to that also again in a later session, but I can quickly summarize this. It's like when we have a mitral valve and the mitral valve has to close, there's actually two phases of closure of mitral valve. One is you have the atrial contraction followed by atrial relaxation, decreasing the pressure of the atrium with regard to the ventricle and starting to drag the valve leaflets towards the atrium. And then you have ventricular activation and contraction, increasing the pressure in the ventricle and then effectively closing the mitral valve. However, if this ventricular contraction, if the pressure buildup of the ventricle is slower than normal, what happens is that there's not enough pressure in order to fully close the mitral valve. And that means that the mitral valve, at the moment that the pressure is starting to be built up very, very slowly, is actually still open. And you see that here when we look at the regurgitation, the mitral regurgitation. So you see here at the onset of the QRS complex, what we see is that we already have mitral regurgitation, which we will call diastolic mitral regurgitation or pre-systolic mitral regurgitation. This is actually before the aortic valve is opening. And then you see is because these are very dilated ventricles with often functional mitral regurgitation, that we also have mitral regurgitation, of course, during the whole ejection period. Now, it looks like this part has very low velocity. So you could think, okay, I mean, this is not a lot of volume going through, but keep in mind that while the mitral regurgitation during the ejection phase is mostly that we don't have full cooptation of the leaflets, but we have a relatively small orifice of regurgitation. At this period, we have the regurgitation because of the fact that the mitral valve has not closed. So that means that the regurgitant orifice is much, much, much higher. So although it's at low velocities, the amount of volume that would go back to the atrium can be actually quite significant in this period. So when you now start to think about all the consequences of this left bundle branch block, so that means that the septum is not contributing anymore. The buildup of the pressure is slow and very inefficient, which means that the lateral wall needs to do everything, and also the time for the ejection is relatively limited. Then we have the relaxation, which is abnormal, which then makes that the filling time is abnormal. And on top of that, so because of its very inefficient mechanics, on top of that also, we have volume loading or additional volume loading because of the fact that the dynamics of the mitral valves are abnormal. So you see why these hearts can go immediately into heart failure. Huh? So it's abnormal contraction and ejection, and abnormal timing, abnormal time periods for both the ejection and the filling, and on top of that, additional volume loading. So that means that they fail dramatically. And that's also why you can see is that there's these patients which are super responders. Huh? So if you correct this with resynchronization therapy, what you see here in this case, also this pre-systolic mitral regurgitation is fully gone in this case. And what you see there is that because of the septum now starts to contribute, what you see is that immediately these patients go out of heart failure almost from the first beat that you're pacing. And you see that they also decrease their size because of the fact that your volume loading is also kind of dramatically decreased. Huh? So you see it's not something which causes one thing, but because of the fact that everything is a little bit too slow, you see that it has a lot of consequences in all the different phases of the cardiac cycle. Now, some people also in the beginning have been saying that this very fast inward-outward motion might actually be not contraction of the septum, but actually can be an interaction between the right ventricle, which is normally activated, and the left ventricle, which is abnormally activated. But there have been some studies, and here is some data from the Oslo group that actually have shown that this septal flash really is related to the contraction of the tissue and the contractility of the septum rather than the interaction of the left and the right. So now there's still one thing which is actually quite relevant and which actually even also makes it worse, that it has other consequences on the function or the whole kind of performance of the ventricle. And that is actually how, in the end, the activation is taking place. And some people that have been doing some mapping, intraventricular mapping of activation, what they've shown is that in some of these patients with left bundle branch block, rather than, as we said before, the septum is normally the earliest activated, and then we have very rapid spread of activation in all directions of the ventricle, and then with the lowest or the slowest activation towards the base of the lateral wall, but at least the activation is taking place from the septum and goes at the same speed in all directions. What happens actually in left bundle branch block, it seems that instead of activation in all directions, what we actually start to see is that the activation is only taking place in one direction. So the activation, instead of spreading homogeneously, is going in one direction, and then is actually turning around the ventricle in such a way that it looks like that there's a line of conduction block. Okay? So that means that if the activation would go in that way, but it doesn't go in this way, it looks like this, for whatever reason, there's a conduction block. Now, this phenomenon of this conduction block seems to disappear when you do pacing. So that means that this is not damaged tissue or not damaged Purkinje system, but it's somehow a functional conduction block. And so the question is, how can we understand this? And so what you can actually show, and this is a simulation that has been done in collaboration with José Felix Rodriguez, what you can see there is, what you can prove is that if there is a conduction which is slow enough, and if you make that tissue which is being stretched would change its conduction velocity, then you can show that there's actually effectively a conduction block, a functional conduction block. So what happens is that if the middle here is activated first, what happens is, of course, when this is activated, it starts to contract, it stretches the surrounding tissue. And if because of this stretching, your conduction velocity becomes lower, what happens is that actually effectively with a certain speed of conduction and a certain dependency on the conduction speed on the stretch, you can prove that you get a halting of the activation up to the point that this stretched tissue is again kind of relaxing, and then you have further activation. Now, is there any evidence that we will get a change in the conduction velocity when we stretch this tissue? Well, yes, because there's two things. One is that obviously when you stretch cells, what happens is that you change their length, and knowing that it's an ion current that happens is, of course, if you increase the conduction path, it will go slower. But the other thing is also that there are in myocytes, there's what's being called stretch activated channels. So you have ion channels which open or close depending on the amount of mechanical force that they see at some point. So this seems to be something that can happen. And does it happen? Well, yes, actually, you can prove that it happens. And here is a study that was done together with KCL in London. And here you see a patient with left bundle branch block. And these are maps. So what you see is a bullseye. Yeah? A bullseye is if we take the ventricle and we actually open it up and project it on a circle so that the middle of the circle is the apex, the surrounding is the base. Here would be the septum, here would be the lateral wall, anterior and inferior. And if you then color this by time of activation, or if you color it by activation or not, and you plot it as a function of time, so here you see a timeline where every bullseye is taken a little bit later. So what you see is that, as we said before, the first activated region is the base of the septum. Then you start to see a spread of this. But what you now see, and this is actually during a time period of maybe 80 milliseconds or something like that, so really a very long time period, you see nothing is happening. So you effectively see a total block of conduction. And then at some point, what you see now is that the conduction is starting again, but you see that here in this case, it whirls anteriorly up to the point that you have a full activation. If you do pacing, so here is a pacing wire, you see that you can actually stop this. But the reason for this is when we now go through the tissue and we take an echocardiography, for example, and we're going to indicate the area of septal flash, so of where you have contraction and where you have stretching. So what you see there is that actually this conduction block happens at the boundary of the contracting and the stretch tissue. And so you really see that this hypothesis, as I said before, where you have stretching of tissue because of early activation, that actually effectively indeed changes the conduction speed. And that makes that the activation is being abnormal. So that means that besides what I said before, that you have the mechanical consequences, then you have the volume consequences, what you actually also have is that there's a functional decrease or functional lengthening of the QRS complex just because of the fact that you will induce a mechanoelectrical interaction that would kind of change the conduction speed. So this, of course, goes a lot against what many electrophysiologists say, is they say like, well, electricity is so fast that we never have to look at the mechanics. The electricity will say everything. But that's not always the case, because here you see that a change in the mechanics can actually induce a change in the electricity and then actually cause these abnormalities. And what you see here is a couple of different patients. We're not going to go in detail, but what you see is that some of these patients, almost all of them, show a functional block. That can the timing of this can depend based on the patient. And then what you also see is that how the activation is taking place, whether it's anterior, or in this case, for example, here and here, it's an inferior whirling, that depends on the patient. And that probably depends on which of the part is relaxing first, and then allows the conduction again. And this way you see that you have these functional blocks. The functional block is not, as they first said with this mapping, is at one side at one point. No, the functional block is fully, but it resolves then only partially when you have the further activation. Now, actually, can you see this in other ways? And yes, you actually can. When you look at the ECG, so as we said before, the QRS complex shows how activation is taking place. And what you very typically see in left bundle branch block patient is that you start to get this kind of QRS fragmentation of notching, so that you see that the QRS complex has like different time phases, different components, where it looks like that you have a period of activation, which then stops, then again activation, then again stopping. And so this is actually the electrical consequence of these functional blocks. And you see that actually when you look at this notching, that this is also very effective in order to detect the mechanical consequences that then, of course, again, can relate to some kind of pacing abnormalities. And you see that these notchings go very, very often together with the mechanical consequences because of the fact that they're so tightly coupled, as I said before. Now, when we look at these interactions, as I said, just very, very briefly, let's still go over this, but again, we come back to that later on. Of course, this septal flash and this kind of early stretching and interaction, this assumes that you have normal tissue, that both the septum is normal and can contract, develop force, and the lateral wall is normal, can contract, develop force, and can be stretched also. So that means that it has to be kind of elastic. Of course, at the moment that we have infarcts, and many of the left bundle branch blocks are actually induced, for example, by infarcts, then what we see is that we will have some kind of consequences of the mechanics of these parts. And so what we see is that if we have a large lateral infarct, for example, so the septum is only contracting, the lateral wall is less contracting, what we see is that we actually don't see the septal flash anymore, because although the septum is early activated, the septum starts to contract, but there's never any counter contraction of the lateral wall. So we do not see that. On the other hand, if we have a septal abnormality, what we see is that it might be that there's still some tissue left that can do the septal flash because of the fact that this is totally unloaded, but we always see this kind of very overt abnormality then during the stretch. So you really see that you always have to think in the mechanical way. It's like which segments are developing force, what is the timing of this, what is the loading or the counter force, when is this happening, what is the elasticity of the tissue, because all of these things will contribute, as we showed before, also based on Hooke's law, for example, to the type of deformation that we can really recognize. Now, to show that this really is because of the differential activation and timing, so what you see here is a animal experiments done in Oslo, where you see here is a left bundle branch block being induced. So you see this septal flash, septal beaking, has it been told also. If you now, instead of having this natural left bundle branch block where the first activation is in the septum coming from the right ventricle, as we said before, if you now very early would pace the lateral wall before the septum is actually being activated, what you see is that you have this lateral kind of flash. So you see here this flash. What you now see is you see actually the two types of contractions or patterns that we said before. So here is a septal flash, a full-blown septal flash with no systolic deformation anymore. Here is one, now in this case a lateral, so a lateral flash, but then again, because the septum is also being activated at some point relatively early, then what you see is there's counter contraction and you see still a little bit of contribution of the lateral wall. But this is to show you that really it's the timing of the activation that is relevant. Come back to this another time. So this is pacing can also induce this. Here is the example of Wolff-Parkinson-White syndrome, where you see that because of the fact that you have these accessory pathways between the atrium and the ventricle, what you see is that here, now in this case, it's the lateral wall line. So you see where there's an abnormal early activation, depending on when it occurs, you really see also, again, this flash-like pattern. So it really depends on the timing and the loading of the surrounding segments, how this goes on. Now, if we look at a patient with non-compaction cardiomyopathy, so as you see before, there's like hypertrabeculation. But when you look here at this activation, so it seems like, so you have activation, and then it seems like you have this kind of second kind of wave. So it's much more subtle than when we really look at a full-blown septal flash in left bundle branch block. But when you do an MO, you see that there is this kind of early activation, and here post-systolic also, that you see in these cases. Now, very often, and here also is like you might have a little bit of a prolonged QRS complex, but you don't see these typical very broad complexes that you see in left bundle branch block. So what will be the reason for this kind of abnormality? Well, for that, we have to go back to the, as we said, to the embryology, where we said before is that during the non-compact phase in the fetal kind of development, what we said before is you have this kind of fetal phenotypes of cells which are fast conducting. Then later on, when we get compaction of the myocardium, what happens is that the Purkinje fibers are forming, and they are forming on top of the trabeculations. So when we look at the Purkinje system, that is actually following the trabeculation pattern and is always on top of the trabeculation. So similarly here also, and you see that nicely in some very specific colorings that is done in a mouse model. So what you see also in non-compaction, what happens is that the Purkinje cells are totally on top of the trabeculations. So now, obviously, what happens compared to normal, where you have Purkinje cells that are activated, and then you have conduction immediately through tissue, what you have here is in non-compaction, you have Purkinje activation, which might be fast, so there is no left bundle branch block. But of course, the further conduction through the non-compacted myocardium will be much slower, and the time that you reach the epicardial wall is much slower because of this complex trabeculation as compared to the normal one. So you see that you have this abnormal and this slow down activation because of the fact that you have this abnormal kind of pathway of the conduction. And here to come back as last case, so here is the fetal case with aortic stenosis. And here you actually see this is a fetus that underwent a valvuloplasty, so in utero valvuloplasty, so where they try to open up the valve within the fetus. And what you see here is when we look at the septal pattern, you see that there is some kind of abnormal kind of pattern that you see here. But after the valve has been opened, what you see there is that the overall contractility is, of course, much better because this ventricle is failing because of the fact that this is a very severe aortic stenosis. You also see that because of this, you have this very abnormal filling pattern, which is very, very short and fused. If you release the stenosis a little bit, what you see is you start to get some normal contribution again. But what you also see is that the septum is not fully contributing, and the septum shows this very typical septal flash pattern, which is, of course, because of the fact that the baby had aortic stenosis. What happens is that, of course, the loading of the wall stresses on the basal septum are extremely high, which would form some fibrosis and could damage actually the left bundle. So left bundle branch block is very good when we have aortic stenosis and severe pressure loading. And so that's what you actually see here. And you see that this pattern, so besides the fact that you have a severe aortic stenosis, this abnormal activation pattern, which makes that the septum is actually totally not contributing to the ejection, well, again, of course, makes this a much worse. And that's why you see that many of these babies with aortic stenosis, even if the stenosis is not super significant, can actually go into heart failure and then have some intrauterine death. Okay, so this is what I wanted to talk about today. So it's clear that if anything changes in the normal cardiac physiology, in this case, the speed of the activation, you see that it has a lot of consequences, and that each of these consequences you can really nicely study and try to reason about. But in the end, what is relevant is that they also cause very typical patterns that you can recognize either based on the images, based on the strains, even on the ECG. So in that sense, this is where also in the future, for example, machine learning can help in detecting and differentiating this maybe in an easier way.